Welcome to ePathshala, subject social medicine and community health. We are still discussing healthcare delivery system, but today we are going to discuss evolution of healthcare in India. Thanks to the principal investigator, Professor C.P. Mishra, and his colleagues. Learning objectives. If we want to learn this particular subject of evolution of health services in India, what do we need to learn? We need to enumerate the stages of evolution in public health in the world, enlist the stages of evolution in public health in India, and describe the various health committees in India. Because whenever we are going to talk of public health services, at some point of time, they were initially at a very rudimentary stage. And by means of additions, by means of problems arising, by means of actions taken, and reviewing the methods, reviewing technologies available, reviewing intelligentsia available, thus the evolution of public health occurs. Now, in introducing, now what is health? Health is actually a positive state of well-being in which the harmonious development of physical, mental capacities of an individual lead to enjoyment of rich and full life. According to the World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Because initially, when we said good health, we mean physically there should be nothing wrong, he shouldn't be ill. But today's definition definitely includes that mentally he should be in a fit condition. Any disturbed person is not in a state of positive health. And socially, he should be at one and in complete balance with his surroundings. And it is not merely, thus, it is not merely the absence of disease or infirmity. What is public health? Public health is actually the science and art of promoting health, preventing disease, prolonging life through the organized efforts of the society, that is WHO, through health promotion, disease prevention, and other forms of health intervention. Public health services are conceptually distinct from medical services, and they have actually a key role in reducing the population's exposure to disease. There we are referring to the population as a whole. We are not talking about individual cases of illness or a group of individuals. For example, assuring food safety and other regulations, vector control, monitoring waste disposal, water systems, health education to improve personal health behavior, and build a citizen demand for better health services. Then poor public health conditions like economic tolls in various ways, including reduced attraction for investors, tourists, all of them actually continued expenditures on combating diseases, which should have become history. So what we are doing is we are actually, because of our inactions or because of slipping back, we have we are continuing to waste public health money, economy, and thereby keeping on poor public health conditions. And it has long been accepted that most effective approaches to improving population health are those that prevent rather than treat disease. It is a norm for public health services to be publicly funded since the market has limited incentives. In India, public policies and programs have actually focused very largely on provision of curative and personal prophylactic interventions such as immunization, but public health activities have been relatively neglected, leading to poor health as well as economic indicators. Now, evolution of public health in the world has actually passed through different stages. These can be segmented into different eras. That is the empirical era until 1850, bacteriological era when bacteriology became prominent, and then with the advent of bacteria being recognized, medicines came into prominence. And after medicines came into prominence, we realized that there were a lot of side effects due to medicines. Thus, the fact that preventive medicine and clinical science era came around about 1900 to 1950s, and Then comes the community health and public health era, 1950 to 1977, and finally, health for all era from 1977 onwards. Hmm. Evolution of public health in India. How has actually public health, not medical health, public health evolved in India? During the pre-colonial period, around 3000 BC, excavation in the Indus Valley at Mohenjo-daro and Harappa showed actually well-planned cities with, in fact, you could see proper drainage and houses and public baths built of baked bricks. They were actually, it seemed that they were very modernized in their own fashion, suggesting very clean practices of environmental sanitation by ancient people. And they had hammams wherein all male members also bathed together, female hammams. So this and they kept a proper show of hygiene and sanitation was very important in ancient public health. Ayurveda emphasized the need for a healthy lifestyle, including cleanliness and purity, good diet, proper. Then came the sadhus, sannyasis, the Brahmins, and thus came Ayurveda. And they dealt in these three doshas, and therefore cleanliness and a different lifestyle of body control, meditation, proper behavior, mental and physical discipline was very important. Purity and cleanliness were to be observed in everything. And finally, we got the medical education was introduced in the ancient universities of Takshila and Nalanda during dominant era of Buddhism and Jainism. In fact, India has seen a lot of changes, a lot of this thing right from the time when there were wars. Alexander came in, the Muslim invasions, then the dominant era of Buddhism, Jainism, all these. And then finally, the Mohenjo-daro, Nalanda, Takshila, they were all well-known institutions of education. During colonial period, the evolution of public health in British India, when the British were ruling over us, this became the evolution of public health was became important. And history of disease prevention in the 19th and the early 20th infectious century, infectious diseases and tropical medicine was a direct consequence of colonialism because this is the knowledge they brought from outside, from their country. And it depicts how the establishment of health systems under the colonial power shaped disease control in British India and to improve the health of the Indian citizens. Although many of the factors may not have fitted into our Indian conditions, yet they were possibly applied. So we had pros and cons in both ways. A medical department was established in 1764 for rendering medical services to the troops and the servants of the company. So East India Company came in, medical department was established by the British rulers, and in 1775, hospital boards were formed to administer European hospitals comprising of Surgeon General, Physician General, etc. In 1785, medical departments were set up in Bengal, Madras, Bombay presidencies with at least 234 surgeons. It was the year 1835 that a more comprehensive system of training was introduced or was instituted in India. In fact, this was the time when the British were ruling over our country and they came with their families. It was the British women, to add a point of interest, who started noticing that there were many maternal deaths. And they were the ones who started going into the labor rooms to help in the labor and to prevent maternal deaths. And that is how the system of training of guys and the system of training nurses for and the importance of maternal and child health with emphasis on bringing down the maternal mortality rate. So sanitary measures were instituted. So with the so that was when the decrease in the deaths of mothers and children, infants was started. The Indian Medical Services were formed in 1896, and the subsequent transfer of public health, sanitation, and vital statistics to the provinces took place in 1990. A school of tropical medicine was established in 1922 at Kolkata in eastern India, which marked a conscious shift from the medical to the public health school. And in 1933, the Medical Council MCI was constituted, which took over the functions hitherto exercised by the General Medical Council of Great Britain for the maintenance of uniform standards for medical education in the country, because that was when, as early as that, the medical schools were started, and they were started in Lahore, Madras, and Calcutta, Mumbai. So these were the start of the first medical colleges. The public health force, workforce, actually constituted personnel from a medical and non-medical background that included ANMs, nurses, midwives, traditional birth attendants, sanitary inspectors, sanitary assistants, health officers, and physicians. So all these people at that time, they were chosen, selected, and put into the framework of medical care and medical health care to be given to the community. But we must be thankful to the British that they started this, and it was beautifully documented and kept and improved to take the shape that it has taken today for an independent India. The establishment of All India Institute of Hygiene and Public Health, Kolkata, in the December of 1932, making it the oldest school of public health in Southeast Asia. And it is still very famous and still working, still functioning. So we are to be proud that we have such an establishment from such a long standing. Now some important milestones. 1764, medical department was established in Bengal, and this was all with the British rulers. Then 1785, medical departments were set up in Bengal, Madras, Bombay presidencies with 234 surgeons. And a superintendent general of vaccination was appointed in India after discovery of the smallpox vaccine. 1835, the Calcutta Medical College was established. 1859, the history of sanitary work in British India began with the reports of the Royal Commission. In 1864, sanitary boards were formed. In 1873, the Births and the Deaths Registration Act was passed. In 1880, an act was passed for compulsory vaccination of children in municipalities and cantonments. 1889, the leprosy bill was passed. So many of the programs which we see today have been their backgrounds and their milestones were laid long time back as far as the 1760s. Then, of course, these are some important milestones, and I must inform you all about it. That is, 1896, the Indian Medical Services was formed. Unfortunately, I still remember the Indian Medical Services was abandoned when we finished medical around about 1965-64. Indian Medical Services was disbanded. And 1896, 1896, the Plague Commission constituted. Then we have the Epidemic Diseases Act, All India Leprosy Act, 1898. New department was constituted in medical colleges with a public health position. They were used to be known as public. Today it is community health, but initially it was public health system. Municipality Local Boards Act were passed. School of Tropical Medicine in Kolkata was established in 1922. All India Institute of Hygiene and Public Health established in Kolkata 32. The Drugs Act was passed 1940. Health Survey, that is 1946, saw a very momentous committee being formed, and that committee was the Boer Committee, which was appointed by the Government of India for the health survey, known as the Health Survey and the Development Committee. We will talk a little bit more about Boer Committee later. After independence, 1947, over the past 6 decades, public health infrastructure and services had undergone remarkable changes and huge expansion in scale and nature based on recommendations by a number of expert committees. Health being a state subject under the Constitution, state governments had undertaken various initiatives to improve healthcare in their respective states. Now, then comes the list of expert committee reports. First is the Boer Committee 1943-1946. The committee constituted in 1943 emphasized the need for social orientation of medical practice, a high level of public participation and consequent development of environmental health, and the two key recommendations were a blueprint for the primary health centers to serve a population of 10,000 to 20,000 was set up, which of course was later corrected to serve a population of 30,000, but now with sub-centers at levels of 5,000 for better approachability. At that time, this was found that primary health centers to serve a population of this would be very large and they would be manned by just one female and one male, which was impossible for them to go around a population of 20,000 to 25,000. So formation of village health committees to obtain the active cooperation and support in development of the health programs. 1959. Now, with this committee being instituted and primary health are set up, it was naturally the thing that each program would come under scrutiny. So, 1959, Mudaliar Committee sat down, strengthening of this, in which they said that we would strengthen the district hospitals, upgrading and strengthening of the PHCs, extension of functions of the University Grants Commission to education in the fields of medicine, and the institution of national programs for malaria eradication, smallpox, cholera, leprosy, tuberculosis, filariasis. This was the beginning of the national programs and levying of a small fee for those availing hospital services, except those who were really poor. And once again, the committees were checked, re-examined, reoriented to form, to let the Chadha Committee now come in 1963. And this committee recommended strengthening of rural health services, vigilance through medical institutions, and developing of multi-purpose domiciliary health services for all health programs. Now, see, these services have been changing from time to time. And it is important that as the years passed by, defects and good points were seen in each and every program. They found that 20,000 population couldn't be seen by one worker. So they upgraded and strengthened the PHC by giving more workers. And University Grants Commission was told to give some grants in the field of medicine. So you had a little bit more money coming in. And then the national programs which were set on their path, starting right from the center to the peripheral level, this was important because this was the beginning of control of the diseases which were spread rampant and which were taking a life toll of our field population. The Chadha Committee, he recommended strengthening again of the rural services and vigilance through medical institutions and developing multi-purpose domiciliary health services for all programs. In this case, that means we were to develop multi-purpose health workers. Now we know there are multi-purpose health workers who are at the primary health center and who are at the sub-centers. So the beginning of these multi-purpose health workers was started, and to lead to Mukherjee Committee in 1965. This was after a very short break. Chadha Committee was there in 63, and within 2 years, Mukherjee Committee came back with a recommendation saying that strengthening of administrative setup from the PHC to the state. So that channel was strengthened. And it also recommended delinking of family planning from the malaria eradication program so that the former can receive undivided attention, because they could see even at that time that the population of India was on an explosive path. So as such, something had to be done to control the population. So family planning received more importance in Mukherjee committee, and this was de-linked from the malaria eradication program to give separate importance to both the programs by themselves. Finally, again in 1965, another committee sat down to review this working, and the Jain committee studied the working of the different hospitals in the country to improve the standards of medical care. The key recommendations were to provide specialist medical care at the district hospitals and improve the capacity and coverage of a PHC to provide maternity facilities. Now, see, uh, slowly, they are introducing important programs with documentation, with training, with money, and to go into the peripheral field level to take care of the population which lives at the grassroots level. Kartar Singh Committee came still later, and they emphasized on multipurpose health workers for the delivery of health and family planning and nutrition services to the community. So now we have the addition. We were already having health, we are already having family planning. Now the introduction of nutrition service to the community. At least one female health worker or an ANM, auxiliary nurse midwife, was to be made available for a population of 10,000, 12,000. Even this much, this at that time was too much, and it is likely to be reduced later on. So this ANM used to go around the population of 10,000 to 12,000, which was too much because it was not possible to cover such a large area. But still, so each primary health center should ultimately serve a population of 50,000 and should have sub-centers spread over it. This was the introduction of the sub-centers. Still, the PHC, if you see the population of PHC was still varying at 50,000, which was too much. And the training for all the workers engaged in the fields of health, family planning, and nutrition. Then came 1974, the Srivastava Committee, and the major courses of action recommended by the committee were organization of basic health services, that is family planning, nutrition, health education within the community itself, and training the personnel for this purpose. Then creation of a national referral service by developing proper linkages between PHC and higher level referral and service centers. And third one, creation of administrative and financial machinery to reorganize medical and health education in tune with the objective of national health services. So as we go through each committee, we come to realize that it is important to find that each one has been looking into these services closely and slowly making it more comprehensive, making it more complete by adding different things. The last one added nutrition. Now this time they are adding organization of basic health services and developing proper linkages between the PHC and then for higher referral level services. That means the FRUs, the idea of first referral units was developed here. Then the national and state health policy. 1978 came the Alma Ata Declaration. The Alma Ata Declaration, a place in Kazakhstan, 78 led to the launch of Health for All by 2000, signed by 137 countries, including India. The declaration advocated provision of first contact services and basic medical care within the framework of integrated health services. The responsibility of the states to provide comprehensive primary health care as per this declaration led to the formulation of the country's first national health policy in 1983. What does this national health policy in 1983 say? An important problem was identified, that was the state of maternal and child health care. Wasn't very effective, wasn't very effective in coverage, effective in services. So therefore, some key indicators were identified, and they were the high infant mortality rate, the maternal mortality rate, life expectancy at birth, crude birth rate and death rate, effective couples. So family planning, MCH, all these factors were taken in. The net protection rate, family size, pregnant mothers receiving antenatal care, deliveries by trained birth attendants and immunizers. So this was the pattern which was recognized and then detailed that we would run on this pattern. Reproductive Child Health Phase 1 program incorporated child health, maternal health, family planning, treatment and control of reproductive health infections. Adolescent health was launched in 1997, and subsequently RCA Phase 2, which aims actually at outcome-oriented program based approach with emphasis on decentralization, move to the field, move. Monitoring and supervision based approach was launched in 2005. The National Population Policy was framed in 2000, and its immediate objective was to address the unmet needs of contraception, healthcare infrastructure, health person, because by this time we were reaching a high level of population, health population explosion. So therefore, this had to be immediately seen to help persons and to provide integrated delivery of reproductive and child health services, that is combine the delivery with the family planning services, with the primary healthcare services, immunization services. So the medium term objective was to bring the total fertility rate to replacement levels by 2010. That means for every woman giving birth to one girl would would replace would be replaced only by that number of females. So the population would not increase. And the long-term objective, so that was actually known as the net reproduction rate. And the long-term objective was to achieve a stable population by 2045. To pursue these objectives, the following national social demographic goals were formulated to be achieved by 2010. Make school education up to 14 age free and compulsory, reduce dropouts at primary and secondary school levels to below 20%. It reduced infant mortality rate to below 30% per thousand live births, reduce maternal mortality ratio to below 100 per thousand, 100,000 live births, achieve universal immunization for children against all vaccine preventable diseases, promote delayed marriage for girls not earlier than age 18 and preferably after 21 years of age. We achieved 80% of institutional deliveries, and we had to achieve at least 100% of deliveries by trained persons. So no delivery was left in the hands of an untrained guide. So either it was a trained guide, or it was a nurse, or it was the lady health visitor, or the auxiliary nurse midwife. Achieve universal access to information and counseling and services for fertility regulation. So everything was being pushed towards achieving a net reproduction rate was one, a good family planning, and a good reproductive child health services. Achieve 100% registration of births, deaths, marriage, pregnancy. Contain the spread of AIDS. Promote greater integration between the management of reproductive tract infections, STIs, and the National AIDS Control Program. Prevent and control communicable diseases, integrate Indian systems of medicine, that is ISM, and the provision of RCA, promote the small family norm to achieve replacement levels, bring about convergence in implementation of related social sector programs so that family welfare became a people-centered program. Then the Millennium Development Goals came into being, and in this, there are actually 8 international development goals that all 193 members. Goal 4 is to reduce child mortality rates with targets to reduce it by two-thirds. Goal 6 to combat HIV and AIDS, malaria, and other diseases, and actually begin the reverse of the spread of HIV and AIDS. Goal 7 to ensure environmental sustainability with a target to integrate the principles of sustainable development into country policies. And finally, to achieve significant improvement in the lives of at least 100 million slum dwellers by 2020. Goal 8, develop a global partnership for development with target to develop an open rule based, predictable, non discriminatory trading and financial system. And as a member of UNDP, India has adopted MDG, wherein goals 3, 4, and 5 deal with public issues, child health, maternal mortality. So all of these actually became important topics. And today, in the National Health Policy of 2002, key area of recommendation was to focus on MCH, its administration, priorities, approach, and goals for 2010. So we have to eradicate polio, jaws, leprosy, kala azar, lymphatic filariasis, HIV, increase utilization of public health facilities, establish an integrated system. So all these had to be achieved by 2010, and today it is 2017. To summarize, the evolution of health services in India from the ancient times, that is pre-colonial times, constituted the Ayurvedic era, the Siddha system. Thereafter, in colonial era, included preventive and curative services based on the allopathic system of medicine. In post-colonial period, post-independence era, various health committees were formed, national health policy was formulated and revised, and Millennium Development Goals were set to improve the health of the country. With this, I thank you for visiting ePaksha.